So, welcome back to my channel. My name is Mark Czujnowski. I am a neuroscientist and a second year medical student. And today we'll be reacting to Grey's Anatomy episode 2. So, I hope you will enjoy. And remember, this is for educational purposes. So, I by no means feel like a huge expert, but I just want to share my knowledge combined with my experience. And yeah, I think Grey's Anatomy is a great place to do it and see how it goes. So if you have any con arguments, if you disagree with something, you can always leave a comment and we can always have a healthy debate. Enjoy.
25-year-old female found down at the park, status post-trauma. She came in with a GCS of 6.
Okay, so she said GCS of 6. GCS means the Glasgow Coma Scale that was developed by two neurosurgeons in 1974 by Sir Graham Teasdale and Mr. Brian Jennett at the University of Glasgow, thus the name. Before its introduction, there was no single universal tool to assess a patient's level of consciousness after head trauma. So different hospitals obviously use different methods, and even when tools were available, they were often purely understood by people using them. So, on top of that, the medical jargon, as you can imagine, was so inconsistent that results could be meaningless to other clinicians. And the GCS changed that. It provided a simple, structured, and standardized approach that could be understood internationally. So, it didn't even matter whether you are in Glasgow, New York, Tokyo, or even somewhere in Antarctica. This universal tool became understandable to everyone. It's also worth noting that Mr. Brian Jennett, together with a neurologist, Dr. Fred Plum, coined the term vegetative state, a concept closely linked to the assessment of consciousness that the Glasgow Coma Scale helps to evaluate. So let's have a look at the table. So we have three domains: eye opening, verbal response, and motor response. The minimum score in each domain is 1, so minimum summed score is 3, which indicates coma or death, with a maximum score of 15 that indicates full awareness and orientation. Here they say the patient's GCS is 6, that's severe head injury.
BP 80 over 60.
Blood pressure of 80 over 60 is hypotension. Hypo means low and tension refers to pressure. So we have low pressure. Normal blood pressure varies among people, but typically the systolic pressure, so when the heart contracts, is about 110, 120, and the diastolic pressure, so when the heart relaxes, is about 70, 80. So since the heart relaxes during diastole, the second value should always be lower than the first one. So such low pressure after trauma more likely indicates blood loss in this young woman.
Exam is significant for blood head trauma. Unequal breath sounds, right pupil is dilated, and she's ready for x-ray.
All right, so blood head trauma, unequal breath sounds, and right pupil dilatation. So let's focus on the head trauma and pupil first. So right pupil dilation. If there is enough light, for example, so if there is enough light, let's say this is your pupil. If there is enough light, or if I start flashing either of your eyes with a direct light from my torch, I should see an immediate constriction of my pupil. However, if I take this light source away from your pupil, I should see an immediate dilation of your pupil. So the pupil should get larger. So if the pupil stays dilated all the time, it strongly suggests damage to the third cranial nerve, so-called the oculomotor nerve. So this nerve starts in the midbrain. Here, runs forward through the skull into the eye, exactly through this hole. Through this hole beneath here. I don't know if you can see it. No, you can see it. No, but anyway, it goes through this hole in the skull into the eye, and this nerve controls most of the eye movements as well as the muscles in the iris. and the iris is the structure that gives the eye its color and control as well pupil size. So damage to this nerve means the pupil on that side can't constrict and stays large. And based on what we see in the episode, and in real life this would be actually visible, we can assume that blunt head trauma is on the right side. That's because the oculomotor nerve on each side controls the pupil on the same side of the head. And next, unequal breath sounds may indicate chest trauma, which can lead to lung collapse, a condition known as tension pneumothorax or other trauma-related issues. So this is actually a red flag that must be addressed immediately. An X-ray is very important because it's quick and can be done without moving the patient out of bed. So using a mobile X-ray, and allows actually us to see what has happened to the lungs, as well as detect other injuries that might not be immediately visible. So after that, the patient needs to be stabilized and assessed accordingly. Oh, put O'Malley and the crash team. Good. Good.
Dr. O'Malley, I'll be running this code. What do we got? We have a 57-year-old male.
Okay, so CPR, assisted.
Asystole.
No, don't charge. Why are you charging him? Like, he's an asystole. So a lot of people think that shocking asystole works because you're just adding electricity to the heart, like jump starting a car. But that's not how it works. A defibrillator does not supply electricity for the heart to run on. It briefly stops disorganized electrical activity so the heart's own pacemaker cells can restart a normal rhythm. Because it's flatlined. Remember when I was talking about the electrical conduction that is going through the heart? So it starts here, it's go downwards, and usually this disorganized activity is in the ventricles, usually. So they are disorganized. They just, firing without any chaotically. So that's why you're just using defibrillator to reset them. That's the only logic behind it. Using a defibrillator on the heart that is flatlined, that does not work, is like trying to reboot a computer that's not even plugged in. So you don't do it. Oh, the blue baby? No. That's quite odd, but okay, so I don't really think so that you would see like an instantaneous color changing of the skin, because there are some congenital heart diseases that would cause like a rapid a discoloration of skin. For example, like transposition of great arteries, where, for example, instead of having aorta in the left ventricle, the aorta is actually in the right ventricle, and instead of having the pulmonary artery in the right ventricle, we have a pulmonary artery in the left ventricle. So instead of delivering oxygenated blood through aorta to the rest of your body, the deoxygenated blood is delivered to your tissues through aorta. So you would expect cyanosis like this one, but not like this. I think it would gradually go from to this state. But what is cyanosis? So as I said, it's basically a discoloration of skin due to deoxygenated hemoglobin. So in other words, red blood cells that carry oxygenated blood to your tissue are not carrying enough oxygen. And we have two types of cyanosis: acrocyanosis, or in other words, peripheral cyanosis, which is usually harmless and affects hands and feet. It's quite common in newborns because they need to adapt from umbilical cord blood to breathing air. And we have central cyanosis, which affects the tongue, lips, mouth, and nose, and is always pathological. Now the baby is not blue. Wait, that's not. That's fine. So, okay, so first of all, once the baby becomes cyanotic, centrally cyanotic, it does not go away. Okay, so that's the first science fiction things, and the second thing is I just don't understand why she's auscultating this baby or this neonate so secretly. So imagine that you're coming to some ward, and let's say that you're seeing a baby with central cyanosis. You don't work on this ward, so you don't really know if the baby has already been handled by the team. You know if they're planning something with the baby. You know nothing. So you're not taking your stethoscope and you're not going to auscultate the baby, because what's the point? What you're doing as a first thing, just going to find somebody like a nurse or a doctor who's looking after the baby, and you can obviously express your concerns, but it's all about the communication, not about secretly auscultating the patient due to unknown reason. So no, but okay, let's see what caused this cyanosis.
Well,
It's a birth defect. Tetralogy of low with pulmonary
Oh.
atresia. You were right.
Whoa, wow. So tetralogy of Fallot is congenital heart disease, but with pulmonary atresia, so it's even the worst case. So let me explain. So tetralogy of Fallot is congenital heart disease, and basically there are four issues. So normally there is a wall between two ventricles. In tetralogy of Fallot, there is a hole between two ventricles. So each time when the blood is coming to the heart, it mixes with oxygenated blood. But the other thing is that also there is a pulmonary stenosis caused by the fact that once there is a hole here, the aorta is being pushed towards this hole. Once the aorta is being pushed towards this hole, it also squeezes pulmonary trunk. And as a result, we either got pulmonary stenosis, so the narrowing of the pulmonary artery, or atresia, meaning that this pulmonary trunk is completely blocked. So what it means that if it's completely blocked, the heart keeps pumping blood, but it can't pump this blood through this pulmonary trunk. As a result, it must pump even harder and harder. As a result, the right ventricle becomes very thick, very muscular. So it can lead to heart failure. So that's the problems, and this case requires like immediate surgery to fix it.
What's wrong with you?
Lost 5 patients on the code team today. I feel like the angel of death.
George, 95% of all code patients can't be revived. Most of them are seriously dead before.
Yeah, so yeah, she exaggerated a little bit, but she's right in the context that the survival rate is quite low. So, for example, in the US alone, in hospital cardiac arrest, there was like each year there's like around 290,000. Approximately 80% of them are non-shockable rhythms, so you don't use defibrillator, and around 25% survive and is being discharged home. The number on the street cardiac arrest is higher because it's around 350,000 each year in the US. And again, the number of non-shockable rhythms is around 80%, but the survival rate is between 10-12%. So although it's not 95%, maybe it varies in different countries. But the truth is that the survival rate once the patient gets into the cardiac arrest is very low. So anyway, so that's it for today. Thank you so much for watching. So I'll make some also. I'll be trying to make some changes, improvements for my videos. And remember, it's we can have fun and we can also learn something new. Take care.